Hello everyone, this talk is about high-yield dysrhythmias, the rhythms you will actually meet on shift and the ones that show up on every board exam. Rhythm problems reward a systematic reader. The physician who asks the same few questions of every strip will catch the diagnosis that panic misses. So we are going to build that system together. Walk through the bradycardias, the narrow and wide tachycardias, the toxic and electrolyte mimics, and the electricity and drugs that fix them. Let's begin. Here is the roadmap. We start with recognition, reading the rhythm strip and the 12 lead quickly and correctly. Along the way we collect ECG pearls, the small findings that change the whole diagnosis. We build a differential for each rhythm because a dysrhythmia is often the symptom of another disease rather than the disease itself. Then we get practical, emergency management at the bedside, medication selection with real doses and real contraindications, and finally disposition, deciding who needs the ICU, who needs telemetry, and who can safely go home. Recognition first, stability always, and the cause behind the rhythm never forgotten. Every dysrhythmia encounter starts the same way before you name the rhythm. Address airway, breathing, and circulation. Put the patient on the monitor. Place defibrillation pads early. Establish IV access, and obtain a 12-lead ECG. Pads on the chest cost nothing. Scrambling for them during deterioration costs minutes. Then ask 3 questions in order. First, stable or unstable. Instability means hypotension, altered mental status, ischemic chest pain, or acute heart failure caused by the rhythm. Second, narrow or wide. A narrow complex means the ventricles are activated through the normal conduction system. A wide complex means ventricular origin or abnormal conduction, and it earns more respect. Third, regular or irregular. Those 3 answers place nearly every rhythm you will meet into a small set of diagnoses. Send glucose, electrolytes, and troponin when indicated, because the answer is often chemical. And the governing rule of this entire lecture: treat instability first. Electricity and resuscitation do not wait for a laboratory panel or a perfect diagnosis. Before we tour individual rhythms, remember that the heart is often the victim rather than the culprit. Run the causes systematically. Electrolyte derangements, especially potassium, magnesium, and calcium, sit at the top of the list. Acute coronary syndrome can present as a rhythm disturbance, and a new dysrhythmia deserves an ischemia evaluation. Myocarditis irritates the myocardium in younger patients. Pulmonary embolism strains the right heart and loves to produce sinus tachycardia and atrial fibrillation. Hypoxia from any cause makes the myocardium irritable, and so does sepsis, where tachyarrhythmias are common and rate control without source control fails. Hypothermia slows everything and produces its own characteristic findings. Thyroid disease swings both directions. Thyrotoxicosis drives atrial fibrillation, while hypothyroidism causes bradycardia. Finally, the toxins: digoxin, tricyclic antidepressants, beta blockers, calcium channel blockers, and stimulants each produce signature rhythm problems. The practical point is this: when you fix a dysrhythmia, ask what caused it, because a cardioverted patient whose potassium is still wrong will simply do it again. Sinus bradycardia is a rate below 60 with normal P waves marching in front of every QRS. Context is everything. In a marathon runner, it is a badge of fitness. In an elderly patient on new medications, it may be the whole story. The differential includes athletic conditioning, inferior myocardial infarction, since the right coronary artery usually supplies the sinus node, medication effect from beta blockers, calcium channel blockers, and digoxin, and hypothyroidism. Treatment is only for the symptomatic and unstable patient. Start with atropine, 1 mg IV, repeated every 3 to 5 minutes to a maximum of 3 mg. If atropine fails or the block is likely below the AV node, move to transcutaneous pacing. Vasoactive infusions are the pharmacologic bridge. Dopamine at 5 to 20 micrograms per kilogram per minute, or epinephrine at 2 to 10 micrograms per minute, titrated to perfusion. While treating, hunt the cause. Review the medication list. Check atropinin and an ECG for inferior ischemia and send thyroid studies when the story fits. Atrioventricular blocks come in 4 flavors, and the dividing line is the level of the block. First-degree block is a fixed prolonged PR interval. Alone, it is benign. Mobitz 1 Venkabach shows a PR that stretches progressively until a beat drops, reflecting block within the AV node itself. It is usually well tolerated and often just needs observation and a medication review. Mobitz 2 is different company. Beats drop suddenly with no PR lengthening because the lesion lies below the node in the His-Purkinje system, and it can collapse into complete heart block without any warning. Complete or third-degree block shows atria and ventricles beating independently with an escape rhythm whose width and rate tell you how low and how unreliable the backup pacemaker is. The differential includes myocardial infarction, Lyme carditis in the right exposure history, age-related conduction system fibrosis, and nodal blocking medications. Management follows the level. Mobitz 2 and complete heart block get pacing pads, a low threshold to pace, and cardiology involvement, while the lower grades usually need monitoring and cause hunting. Supraventricular tachycardia is the regular narrow tachycardia of a young, otherwise healthy heart, classically abrupt in onset, with a rate often near 180 or above, and P waves buried out of sight. If the patient is stable, begin with vagal maneuvers and use the modified Valsalva. Strain against resistance, then lie the patient flat and lift the legs. It converts far more patients than the traditional version. If that fails, reach for adenosine. 6 mg by rapid push through a large bore IV with an immediate saline flush, followed by 12 mg if the first dose fails, and current adult guidance stops after 1 repeat. Warn the patient about the brief, awful sensation of impending doom. It lasts seconds, and the warning preserves their trust. Record a rhythm strip during administration because the response can unmask flutter. If the patient is unstable, hypotensive, altered, or in ischemic pain, skip the drugs and perform synchronized cardioversion. After conversion, obtain a 12 lead to look for pre-excitation before choosing follow-up. Atrial flutter announces itself with sawtooth waves best seen in the inferior leads, and with a ventricular rate that is suspiciously regular, classically near 150 when the circuit conducts 2 to 1. Any regular narrow tachycardia parked at that rate should make you hunt for flutter waves, and vagal maneuvers or adenosine will slow conduction enough to expose them without converting anything. Rate control uses the standard AV nodal agents. Diltiazem 0.25 mg per kilogram IV over 2 minutes with an infusion to follow, or metoprolol 5 mg IV repeated as tolerated, watching the blood pressure with either choice. Flutter tends to be stubborn with drugs but delightfully responsive to electricity, converting at low synchronized energies, so cardioversion is a reasonable early choice in the appropriate patient. The anticoagulation rules mirror atrial fibrillation exactly. the same duration questions, the same stroke risk scoring, and the same requirement for anticoagulation or thrombus exclusion before elective cardioversion beyond 48 hours of onset. Atrial fibrillation is the irregularly irregular rhythm with no organized P waves, and its etiologies are worth reciting because they drive management. Hypertension, heart failure, sepsis, alcohol, whether the holiday binge or chronic use, and hyperthyroidism. In the ED, the rate question comes first. Diltiazem or metoprolol at the doses we just covered, chosen partly by comorbidity, with the calcium channel route avoided in decompensated systolic heart failure, but the higher yield habit is asking why the rate is fast. The septic patient in atrial fibrillation at 140 needs fluids and antibiotics more than another dose of diltiazem, and slamming the node in a compensating patient can cause real harm. One trap owns this slide. In pre-excited atrial fibrillation, the wide, bizarre, irregular tachycardia of Wolff-Parkinson-White. Every AV nodal blocker is dangerous. Adenosine, diltiazem, verapamil, and digoxin included, because blocking the node shoves conduction down the accessory pathway toward ventricular fibrillation. That patient gets procanamide or synchronized cardioversion. Anticoagulation decisions then follow stroke risk and episode duration. Wide complex tachycardia has one rule that outranks all others. Assume ventricular tachycardia until proven otherwise. The majority of wide complex tachycardias are VT. The proportion climbs with age and structural heart disease, and the penalty for the wrong assumption is asymmetric. Treating VT as SVT with a nodal blocker can produce arrest, while treating SVT as VT is generally safe. The differential includes VT-SVT with aberrant conduction, hyperkalemia, tricyclic antidepressant toxicity, and pre-excited rhythms in Wolff-Parkinson-White. Notice that two of those are chemistry problems. A slow, wide, strange rhythm in a dialysis patient is potassium until proven otherwise and gets calcium, and a wide QRS after an overdose gets sodium bicarbonate. For the rest, stability decides the path. Unstable patients receive synchronized cardioversion immediately. Stable patients can trial an antiarrhythmic procanamide or amiodarone with pads on and the cardioverter within reach. Do not use verapamil or diltiazem in undifferentiated wide complex tachycardia. That is a classic board question and a classic real-world disaster. For monomorphic ventricular tachycardia with a pulse, stability picks the tool. The unstable patient, hypotensive, altered, ischemic, or in failure gets synchronized cardioversion without delay. For the stable patient, two drugs dominate. Amiodarone is the familiar choice. 150 milligrams IV over 10 minutes. Repeatable if the arrhythmia persists, followed by an infusion, and it is preferred when the ejection fraction is poor. Procanamide is arguably the better performing agent in stable monomorphic VT. Load at 17 milligrams per kilogram, infused at 20 to 50 milligrams per minute, and stop early for hypotension. For QRS widening beyond half again its baseline, or when the arrhythmia breaks. Avoid procanamide in significant heart failure and in prolonged QT. Whichever agent you choose, leave the pads on and be ready to cardiovert, because drugs fail and patients declare themselves suddenly. Check and replace potassium and magnesium. Look for ischemia as the trigger, and admit these patients to a monitored critical care bed with cardiology and electrophysiology involved. Torsade de Pointes is polymorphic ventricular tachycardia twisting around the baseline, and it grows out of a prolonged QT interval. The setup is usually a QT prolonging medication layered on hypokalemia or hypomagnesemia, with bradycardia and pauses providing the trigger. The classic sequence is pause, then Torsade. Treatment starts with magnesium sulfate, 2 grams IV, given over minutes in the perfusing patient and pushed in the arrest, and it works even when the measured magnesium level is normal. Replete potassium toward the high end of normal, and stop every QT prolonging drug on the list. Because Torsade is pause dependent, recurrent runs respond to making the heart go faster, overdrive pacing, or an isoproterenol infusion as a pharmacologic bridge in acquired cases while pacing is arranged. If the patient loses a pulse, this is a shockable arrest, so defibrillate and run the standard algorithm. Sustained recurrent Torsade belongs in an ICU on continuous telemetry with the QT tracked until it normalizes. Ventricular fibrillation has the simplest algorithm in medicine and the least forgiveness for delay. Defibrillate immediately the moment the rhythm is recognized and the pads are on, because survival falls with every minute of fibrillation. Between shocks, deliver uninterrupted high-quality CPR, resuming compressions the instant the shock is delivered without waiting to reanalyze. Epinephrine, 1 milligram IV or IO, begins after the second shock and repeats every 3 to 5 minutes. For fibrillation refractory to defibrillation, give amiodarone, 300 milligrams IV push with a second dose of 150 milligrams if needed. While the algorithm runs, the team leader's job is thinking, work through the reversible causes, keep compression interruptions to an absolute minimum, rotate compressors before quality fades, and plan the next shock so charging happens during compressions. When circulation returns, move immediately into post-arrest care and ECG, hemodynamic support, and temperature management in an ICU. The lesson to carry: in ventricular fibrillation, electricity is the treatment, and everything else exists to support it. Wolff-Parkinson-White syndrome is an accessory pathway bypassing the AV node, and on the resting ECG it shows a short PR interval with a delta wave that slurred upstroke at the start of the QRS. The danger arrives with arrhythmia. In orthodromic reentrant tachycardia, a regular narrow tachycardia, the node is part of the circuit and standard therapy works. The lethal scenario is atrial fibrillation conducting down the accessory pathway, an irregular, wide, bizarre tachycardia with rates that can exceed 250. In that rhythm, avoid adenosine, diltiazem, verapamil, and digoxin absolutely, and treat beta blockers and amiodarone with the same suspicion, because anything that preferentially blocks the node accelerates conduction down the pathway and can degenerate the rhythm into ventricular fibrillation. The correct answers are procainamide, which slows the accessory pathway itself, or synchronized cardioversion, which is always right when in doubt, or when the patient is unstable. After conversion, these patients need electrophysiology referral since pathway ablation is curative. Write the diagnosis clearly on the chart. The next physician's drug choice depends on it. Brugada syndrome is a sodium channelopathy that causes sudden death in structurally normal hearts, and you find it by looking at the right precordial leads. The type 1 pattern is coved ST elevation of at least 2 millimeters in V1 through V3, sloping into an inverted T wave, sometimes with a pseudo-right bundle branch appearance. It matters because these patients die from polymorphic VT, often in sleep, often young, and the ECG may be the only warning. The pattern waxes and wanes, and fever famously unmasks it, so treat fever aggressively with antipyretics in any patient with a known or suspected Brugada pattern, and take a febrile syncope story seriously. Avoid sodium channel blocking drugs, including class 1 antiarrhythmics such as procainamide and flecainide, because they can provoke the arrhythmia. The same logic applies to tricyclic overdose, mimicking the pattern. Ask about syncope and a family history of sudden unexplained death. Definitive therapy is an implantable defibrillator in appropriate patients. So symptomatic or high-risk findings earn admission and electrophysiology referral, never a routine discharge. Long QT syndrome comes in two families. The congenital form is a channelopathy presenting in the young, classically with syncope or sudden death triggered by exertion, emotion, or startle, and a family history that repays careful questioning. The acquired form is far more common in the ED and is drug-induced. Antiemetics, antipsychotics, methadone, macrolides, fluoroquinolones, and antifungals headline a long list, usually conspiring with hypokalemia or hypomagnesemia. Measure the corrected QT yourself rather than trusting the machine, and treat a value beyond 500 milliseconds as a red flag for torsade. Management is straightforward. Give magnesium, replete potassium toward high normal, and stop every offending drug, which means actually reading the medication list, line by line. For congenital disease, beta blockade is the long-term backbone, and catecholamine infusions like isoproterenol should be avoided. That distinction from acquired pause-dependent disease is a favorite examination point. Symptomatic patients, those with syncope, documented arrhythmia, or a markedly prolonged interval, stay on a monitor and get cardiology involved before disposition. Hyperkalemia is the dysrhythmia mimic that kills while the sample writes to the lab, and its ECG progression should live in your memory. Peak T waves first, then PR prolongation, then QRS widening, and finally the sine wave that immediately precedes arrest. A wide, slow, bizarre rhythm in a dialysis patient is hyperkalemia until proven otherwise, and you treat the tracing, not the pending result. Calcium comes first, stabilizing the myocardium within minutes without moving the potassium. Calcium gluconate 3 grams IV peripherally, or calcium chloride 1 gram through a reliable line, repeated if the QRS stays wide. Then shift potassium into the cells. 10 units of regular insulin IV with 25 grams of dextrose, monitoring glucose afterward, plus high-dose nebulized albuterol with bicarbonate reserved mainly for the acidotic patient. Shifting buys time, it removes nothing, so arrange definitive elimination with dialysis for the renal failure patient or diuresis and binders when kidneys still function. Then find out why the potassium rose, or you will be repeating this sequence tomorrow. Digoxin toxicity is worth knowing cold because the drug persists in an aging population with narrow margins. The mechanism, sodium-potassium pump inhibition plus increased vagal tone, produces a signature combination, increased automaticity above with conduction block below. So think digoxin when you see atrial tachycardia with block, accelerated junctional rhythms, frequent ventricular ectopy, or AV block. And remember that bidirectional ventricular tachycardia, with the QRS axis alternating beat to beat, is nearly pathognomonic. Chronic toxicity in an elderly patient with renal impairment can look like fatigue, confusion, nausea, and visual changes. The antidote is digoxin immune fab, given for life-threatening dysrhythmias, hemodynamic instability, or significant hyperkalemia in acute overdose, where the potassium level tracks with mortality. Handle electrolytes thoughtfully. Hypokalemia and hypomagnesemia worsen toxicity and need repletion, while the hyperkalemia of acute poisoning is treated with FAB rather than aggressive shifting, and calcium is best avoided when FAB is available and the diagnosis is clear. Avoid cardioversion when possible. If it is unavoidable, use low energy. These patients are admitted to monitored beds. Synchronized cardioversion is the treatment for unstable tachycardia with a pulse, and the word synchronized is doing real work. The machine times the shock to the R wave, avoiding the vulnerable period of the T wave, where an unsynchronized shock can induce ventricular fibrillation. Press the sync button, confirm the markers are landing on each R wave, and remember that many machines drop out of sync mode after every shock, so recheck before each attempt. Energy selection by rhythm, supraventricular tachycardia and atrial flutter convert at 50 to 100 joules. Atrial fibrillation needs more, 120 to 200 joules biphasic, and monomorphic ventricular tachycardia starts at 100 joules, escalating whenever a shock fails. In the conscious patient, provide procedural sedation whenever the clinical situation allows. Cardioversion is momentary, but patients remember it. Pad position matters less than firm contact, and anterior-posterior placement is a reasonable choice for atrial fibrillation. If the rhythm is pulseless or the synchronizer cannot find an R wave, abandon synchronization and defibrillate. Defibrillation is the unsynchronized shock, and it has exactly two indications: ventricular fibrillation and pulseless ventricular tachycardia. There is no timing to respect in a chaotic rhythm, so the machine discharges immediately. With a biphasic defibrillator, use the manufacturer's recommended energy, typically 120 to 200 joules, and when you do not know the recommendation, choose 200 and move on. Underdosing electricity in a shockable arrest helps no one. The choreography around the shock matters as much as the energy. Charge the defibrillator during ongoing compressions, clear the patient efficiently with the practice phrase, deliver the shock, and resume compressions immediately without pausing to study the monitor or feel for a pulse. The rhythm gets its analysis at the next 2-minute mark. That single habit, immediate CPR after every shock, protects the compression fraction that drives survival. Escalate energy for refractory fibrillation if your device allows. Consider changing pad position, and keep the epinephrine and amiodarone sequence running alongside the shocks. Transcutaneous pacing is the bridge for symptomatic bradycardia that atropine cannot fix, and the skill is in confirming it actually works. Place the pads, set a rate of 60 to 80 beats per minute, and increase the current from low output until you see electrical capture. A pacer spike followed by a broad QRS with a discernible T wave. Then prove mechanical capture. Palpate the femoral pulse or use the ultrasound, because muscle twitching and monitor artifact routinely masquerade as success, while the patient quietly remains in shock. Set the final output modestly above the capture threshold to hold reliability. Pacing hertz in the conscious patient provide analgesia and sedation, titrated carefully in someone who is already hypotensive. Transcutaneous pacing is a bridge, not a destination. Skin burns and capture failure accumulate over time, so its purpose is to buy minutes to hours while you correct reversible causes and arrange transvenous pacing with cardiology. If capture cannot be achieved, return to the vasoactive infusions, epinephrine or dopamine, and escalate quickly. Let's put the antiarrhythmic toolbox in one place. This is the slide to know before a night shift. Adenosine 6 mg by rapid push with a flush, then 12 mg for regular narrow complex tachycardia, never for irregular wide rhythms. Amiodarone 150 mg IV over 10 minutes for stable ventricular tachycardia. 300 milligrams push in shockable arrest with 150 as the repeat, followed by an infusion. Watch for hypotension. Procainamide, 17 milligrams per kilogram, loaded at 20 to 50 milligrams per minute, the strong choice for stable monomorphic VT and the drug of choice in pre-excited atrial fibrillation. Stop for hypotension or marked QRS widening and avoid it in heart failure and long QT. Lidocaine 1 to 1.5 milligrams per kilogram, the alternative for ventricular arrhythmias, particularly when ischemia is the suspected driver. Magnesium 2 grams IV for torso de pointe, regardless of the level. Doses win resuscitations when they come automatically, so rehearse these until they do. Rate control drugs deserve the same fluency. Metoprolol 5 milligrams IV, repeatable every few minutes for 2 or 3 doses. A beta blocker suited to patients with coronary disease or thyrotoxicosis. Esmolol, a bolus followed by an infusion, ultra short acting and titratable, which makes it forgiving in patients whose blood pressure worries you, and the beta blocker of choice when you may need to turn the effect off quickly. Diltiazem, 0.25 milligrams per kilogram IV over 2 minutes, then an infusion, reliable for atrial fibrillation and flutter, but a poor choice in decompensated systolic heart failure, where its negative inotropy can tip the patient over. Digoxin, slow in onset and rarely a first choice, but useful for rate control in the hypertensive heart failure patient who cannot tolerate the others. 2 contraindications rule them all. Significant hypotension, where nodal blockade converts a compensating patient into a shocked one, and pre-excited atrial fibrillation, where every one of these agents is dangerous and the answer is procainamide or cardioversion. 4 ECG pearls carry a disproportionate share of rhythm diagnosis. First, a wide regular tachycardia is ventricular tachycardia until proven otherwise, whatever the blood pressure and however comfortable the patient looks. Stability never rules out VT. Second, a wide, irregular, chaotic tachycardia, especially with beat-to-beat variation in QRS shape, is atrial fibrillation with pre-excitation until proven otherwise, and the entire AV nodal blocking shelf is off limits. Reach for procainamide or the cardioverter. Third, inferior myocardial infarction commonly produces AV block because the right coronary artery supplies the node in most people. The block is usually nodal, often atropine responsive, and frequently transient. But it means an inferior STEMI needs pads placed and a pacing plan. Fourth, hyperkalemia is the great imposter, capable of mimicking STEMI with pseudo-elevation, producing wide complex rhythms and flattening P waves entirely. In the renal patient with a strange tracing, give calcium first and argue about the differential afterward. Tape these 4 to the inside of your skull. Here is the whole lecture compressed into the ACLS view. For bradycardia, if the patient is symptomatic, give atropine 1 milligram, repeating to 3 milligrams total. When it fails, move to transcutaneous pacing with a vasoactive infusion as the bridge, and remember the infranodal blocks that atropine will not touch. For tachycardia, the unstable patient gets synchronized cardioversion now. The stable patient gets sorted, narrow versus wide, regular versus irregular, and receives vagal maneuvers, adenosine, nodal blockers, or an antiarrhythmic accordingly, with procainamide standing by for the pre-excited trap. For ventricular fibrillation and pulseless VT, shock immediately, resume compressions, epinephrine every 3 to 5 minutes beginning after the second shock, then amiodarone for what persists, all while hunting reversible causes. The algorithms exist so your hands keep moving while your brain works the differential. Instability means electricity. Chemistry problems mean chemistry answers. and the cause behind the rhythm always gets chased. 4 take-home points from this hour. Treat unstable patients immediately with electricity when the rhythm is the problem. Nothing on the laboratory printout outranks a crashing patient. Correct reversible causes, especially potassium, magnesium, ischemia, and drugs, or the dysrhythmia will simply return. Know your ACLS doses: cold, atropine, adenosine, amiodarone, procainamide, magnesium, and epinephrine, because recall under pressure is a trained skill. And assume every wide complex tachycardia is ventricular tachycardia until proven otherwise. Master those 4 habits, and you will handle nearly every rhythm the department can throw at you. Thanks for your attention.